before we start. So next Grand Rounds is October 17th, and our speaker will be Brecken Hentz, who's the lead speech pathologist over at the VA, who will be talking about dysphagia management. Our next journal club will be next Thursday, October 8th, and that will be led by Doctors Andrea Stand and Hillary Lum. Other announcements: there is a Geriatrics Division Zoom meeting following today's Grand Rounds, so please make sure you get on for that. After Grand Rounds today, you'll receive an email with a link to the recording of today's presentation and a copy of the PowerPoint, as well as a link to an online evaluation. So if you could please fill that out, that's really helpful to the speakers and to us. If you have questions that come up during the presentation or have questions you want to address at the end, please submit these in the Q&A box anytime during the presentation, and we'll get to those hopefully at the end of the presentation. So it's my pleasure to introduce our speaker this morning, Dr. Eric Schatz. Dr. Schatz has been with the University of Denver since 2017. He is a physician and a lawyer with a focus on prevention, well-being, and financial security. In his role, he directs the Financial Security and Cognitive Health Initiative at the Noble Institute for Healthy Aging, and also leads the Executive Healthcare Administration concentration for the university's online MBA program at the end of College of Business. We're really excited to have Dr. Schatz here this morning to talk with us about financial security and cognitive health. So welcome, Dr. Schatz.
Thank you so much, Carrie. Can everyone hear me, hopefully? Well, it's great to be here in this virtual setting. I really appreciate the invitation to speak. It's been a great joy to get to know a bunch of you and our shared interest in improving the lives of older adults. And I'm excited to talk about the intersection between financial decision-making and cognitive health. One quick note, my initiative has recently gone through a name change. We were the Financial Security and Cognitive Health Initiative, and through some generous donations, we are now called the Paul Freeman Financial Security Program in honor of a dear member of our DU community who passed away recently, and in honor of him, we are now the Paul Freeman Financial Security Program. But so there's both names that appear around, as you'll see. So, I'd like to start by framing the challenges associated with cognitive impairment and dementia, dementia from all causes. By age 70, around 1/8 of the population has some form of cognitive impairment or dementia. These numbers are difficult to come by in terms of all-cause dementia and cognitive impairment. So they're kind of general numbers, and there's a fair amount of argument over them, but the general thought holds. By age 75, that number increases potentially to 25% of the population. And by age 80, a full 50% potentially has some form of cognitive impairment or dementia. Now, when you look at the demographics of the country, Americans 65 and older, you can see that in 2013, we had around 45 million. That will go up to around 72 million. And by 2060, potentially 98 million of Americans are 65 and older. So it also starts to tell you in terms of cognitive impairment and dementia that we have a real challenge on our hands if things were to continue the way they are right now. Now, the annual costs of dementia, and this is from the Alzheimer's Organization numbers, total healthcare costs around annually $290 billion. And then when you factor in the value of unpaid caregivers, that's another $234 billion. And per person costs, and this is total healthcare and long-term care costs from all sources in Medicare beneficiaries. And so if there's no dementia, annual per person total healthcare costs around $14,000. If with dementia, that shoots up to closer to $50,000, and a lot because of the comorbidities associated with dementia, as you all know. So what does any of this have to do with financial decision making? Well, it turns out that the earliest markers for any decline in cognitive function are often found in impaired financial decision making. And this can be years and perhaps even decades before you notice any other signs or symptoms. The financial decisions that this encompasses has been studied over the last 20 years now. It can be everyday cash transactions. It can be making tips, making change, detecting fraud risk, prioritizing bill repayment, investment decisions, savings decisions, spending decisions, etc. So why is this? Financial decision-making encompasses a wide array of cognitive tasks that need simultaneous attention, including, there's clearly an element of mathematical processing for sure, but that's not it. There's risk assessment, there's judgment, there's emotions, there's relationships sometimes that go into one relatively common financial decision. Further conceptual framework to look at this is that we all have two types of intelligence. First is crystallized intelligence. As we age, we accrue knowledge, wisdom, intelligence in the crystallized sense is based on our life experiences and our education. And as we accrue this knowledge, wisdom, and experience, this goes up and up. And as you can see, it continues to increase until it potentially plateaus in our 70s. There's a fair amount of more recent evidence that shows that it doesn't even have to plateau like this. If you think of your brain like a computer, we essentially, crystallized intelligence is like our hard drive. And we have essentially an unlimited hard drive that we can keep on packing into it. So that's the good news. The other side of the coin is fluid intelligence. Fluid intelligence, if you're thinking of your brain like a computer, this is our processing speed. The information might be in there, but how quickly do we have access to it? How quickly can we manipulate that information? Fluid intelligence, the processing speed, the access, the working memory, reasoning, analytic function can be involved, abstract thinking, spatial visualization. This type of intelligence is independent of education and knowledge. And fluid intelligence generally peaks in our 20s and then steadily declines thereafter. Also, a fair amount of evidence to suggest that the slope of this line doesn't have to be quite as steep depending on what we do with our lives. Now, the peak of our financial abilities through research in the last 20 years turns out to be in our early 50s. And this is where we have a fair amount of crystallized intelligence, and our fluid intelligence hasn't dropped off too much. And so we peak in our early 50s, and at 53 based on one of the major studies. Another set of studies look at real versus perceived financial acuity. And when looking at objective financial knowledge or financial acuity, they essentially confirmed from the last slide that this peaks in our early 50s and then has a steady decline in terms of objective knowledge or objective financial acuity. The interesting thing about this different set of studies is they also inquired about the confidence level of people making the decisions, their confidence in their financial decisions, and found that essentially confidence might remain high despite the fact that financial knowledge or acuity can be declining. This part of the graph, as the lines move away from each other as we age, is very concerning. Now, the people who love this graph and feed off it are people who commit fraud and exploitation. Exploitation or fraud and abuse in this country for people over 60 causes around $3 billion a year. And again, these numbers are very, very difficult to really nail down to general estimates. And some think that actually these are much less, that there's less reporting and the numbers are actually much higher than they appear here. If you expand out this definition from fraud and abuse to exploitation, not quite meeting the level of fraud and abuse, this number skyrockets to $36 billion a year, and potentially that also is an underestimate. The scams used to be a handful of scams that governments would try to get out in front of and let people know. And now the common scams, there are pages and pages of them. So this is just an example of many of the scams that are out there currently, but they continue to grow, unfortunately. And with the with the current pandemic brings a current new set of COVID-19 specific related scams, unfortunately. And so this can be all sorts of things, there's a new test, there's a new treatment, there's a cure, there's relief check scams where you sign for stuff. And a lot of this is about getting personal information. There's the text on your phone that you have been in contact with someone with COVID, and you need to either call this number or you click on this, and before you know it, you're down the rabbit hole. So unfortunately, these have been exploding, around 200,000 complaints since around late February for at least 140 million. That's generally thought to be way underreported as well. So the scam categories generally fall into three different categories. There's telemarketing, which is still very, very prominent and has been prominent in our older adults. It has become more prominent with increased social isolation for everyone. But telemarketing, door-to-door, and of course the internet, major categories of scam and exploitation. There's even a new vocabulary around all this stuff. And so it's maybe started with hacker and virus, not the COVID-19 virus. But maybe some of you know all these words. I certainly didn't when I started in this field a few years ago. And that vocabulary is growing too. So the perpetrators of exploitation and fraud, it's important to know, this can be anyone from telephone callers and texters, door-to-door solicitors, the regular mail, email, internet, and unfortunately, even financial advisors. And even more unfortunately, a lot of times the people who are closest to us, caregivers, family, friends, can be people to perpetrate exploitation and fraud. And a lot of this that we always bring up is not necessarily because of malicious intent, but because of circumstance and opportunity and the feeling that you're going to pay it back, and things just kind of get worse and worse. And so it doesn't always have to be because of a lack of love and support in a relationship that this fraud and exploitation can take place. So decreasing the risk of fraud and exploitation involves certainly increasing the awareness of these scams that are out there and the types of perpetrators and situations. And governments and communities do a really good job, and they're always trying to get out in front and let people know what's going on. From our standpoint, this is a bit of playing whack-a-mole with the types of exploitation and scam, because they're the people who are committing these this fraud and exploitation. They're smart, and they're always one step ahead, and we're always potentially one step behind. So really, it's more from our standpoint, the thing that we need to really focus on is the behaviors that may increase risk. So why are older adults at risk? One reason: accumulated assets, certainly. Social isolation, so higher risk of social isolation with older adults. And as I mentioned, though, this is now much more prevalent in the entire community. Changes in health status make us at higher risk for fraud and exploitation, financial fraud and exploitation. Receiving assistance from a caregiver, unfortunately, puts us at increased risk. And certainly cognitive decline and impaired financial decision-making. Now, it should also be pointed out that younger adults are also at risk for financial fraud and exploitation. They're just at risk for different reasons. In fact, some studies have shown that millennials are more likely to be defrauded just for much less amounts, and they obviously have a greater ability to bounce back from losing a certain amount of money, whereas an older adult, if it's a life savings, that can be a tragic situation. So for the young people, some of the reasons involved are impulsiveness or optimism bias or a low crystallized intelligence. And unfortunately, even kids are not immune to some fraudulent financial behavior, including identity theft. Now, what we focus on is there's a lot more than just the fraud and exploitation aspect. Suboptimal financial decision-making decisions can be completely unrelated to fraud and exploitation and affect many, many areas of our life, and potentially for much, much more amounts over time than fraud and exploitation, which hopefully many of us don't experience. And this can be in all sorts of areas: housing and healthcare and social security and retirement accounts and debt management, spending, savings. You can imagine that suboptimal financial decision-making affecting all these over time could have a very, very significant effect on lots of people who are not subject to fraud or exploitation. So it takes me to financial well-being. Well, what really is financial well-being? There are a lot of definitions, and there's some that are agreed upon around the country. And this includes protection, certainly from fraud and exploitation, but also having control over day-to-day, month-to-month finances, capacity to absorb financial shocks, being on track to meet financial goals, and the financial freedom to make choices to enjoy life. As you can see here, none of this is described by an objective measure of finances. But what's missing from this definition? What's missing generally from our standpoint is stress, anxiety, and the relationship between stress, anxiety, and money. The perception of financial well-being turns out to be very important in this field. Also may be at odds with objective measures of financial well-being, meaning that you could have plenty and still your finances are a cause of significant amount of stress in your life, which can cause other things, as we all very well know. On the other end of the spectrum, well, you can have enough and not be so worried about it. And so again, it's potentially at odds with objective measures. But it turns out that perceived financial well-being is a key predictor of overall well-being. And this just gets into what we do all know very well is the importance of stress and anxiety in our lives and how that affects our health overall. So the American Psychological Association does a study every year reporting on stress in Americans and what stresses us out the most. And every year, generally, there are three things at the top of the list that jockey for positions. And one is your health or the health of a family member, certainly. But always in the top three is your finances in terms of what's causing you the most stress in your life is your financial situation. Now, the other one, interestingly, and for the last many years and maybe even the last two nights for plenty of people, the other one is the state of the country politically. And so as a major cause of stress for a lot of people. But we focus on the financial one. That's the work that we're doing. And since it's up there and a major cause of stress and anxiety, this perceived financial well-being is very, very important to us. So the goal is really to maximize both real and perceived financial well-being. So when you look at some of the numbers on financial security, only 47% of Americans have enough money to cover 3 months of expenses. And this is a report done by Pew this year, Pew Research. And during the pandemic, you can imagine how difficult this is making things for lots of folks. When you break this down, also it becomes even more concerning for some similar reasons that we see in all ranges in health and healthcare. But break it down by race, break it down by age, break it down by education and income, and you can see that the people potentially who are most vulnerable are potentially getting hurt the most. Now, also on this for older adults, well, older adults, as we've discussed, have more assets overall. And so just based on the age, you can see that, well, they're in the higher percentage of people who do have enough money to cover those 3 months of expenses. But these are people who are potentially looking to cover years and years of expenses. So it's still very significant. So the solution, here's one solution, and that's that we, at age 65, we get divorced and marry other people who planned much better. And so that's one solution. We're not, we have other ones. So if that's what you're thinking, that's all we have. We've got more on the table for you. The consensus solution for many years on this issue has been to increase financial education. And that's great. It sounds good. There's almost no one who's against education. And it sounds great. And so there's programs out there. We're spending time and effort and money and resources on financial education. Now, the problem is it's generally not working as well as we want, or not working at all in some instances. Some of the literature on this has shown that objective financial knowledge has only modest correlation with financial behavior. So you can learn all you want, but if it's not changing your behavior, then in all these things that we've talked about, whether it's exploitation, fraud risk, or all the other categories that are non-exploitive or fraudulent, you might know plenty and still not behave in ways that are optimizing your finances. And the other big one is, well, financial education interventions themselves have had very little effect in moving the needle. So this is obviously concerning because from our standpoint at our initiative it's nice to have things where we can pat ourselves on the back for, but if they're not actually really achieving any impact, then why are we doing them and why are we spinning our wheels and spending this money and time? So why is it unsuccessful? Because we don't want to throw it away. We're big believers in education, as you can imagine. Well, we discussed financial decision-making is complex, right? There's mathematical processing, but there's risk assessment, judgment, relationships, emotions, age-related differences in how we learn, and intelligence, and predictably irrational decision-making. And this is also known as prospect theory. Prospect theory represented a major shift in economic theory, resulting in a Nobel Prize in economics. And this was many years ago, decades now. Interestingly, the Nobel Prize in economics for prospect theory was awarded to people who were not economists. They were psychologists. This is Daniel Kahneman and Amos Tversky, who basically put some of our economic thinking on its head with how we make decisions. So let's get into some of those predictably irrational financial decisions that we all make. So let's say you have 2 credit cards. You've got account A, which has a balance of $300, and you're paying a 6% interest rate on that account. And you have account B, it's got $3,000 of a balance in it, and that's a 12% interest rate. And let's say normally you pay off your minimum balances like you have to, and that's pretty much all the money you have, but you're paying off your balances until fortunately you come into some money, you receive a gift. However, you get $500 extra cash, and you know that paying off debt is a very, very important thing. So what do you do, and what do most people do regardless of their education level? Well, people are more likely to pay off account A than to pay down account B. But that's, on the face of it, a financial mistake. With those interest rates, any money that you have should go to paying off the higher interest rate. And plenty of people know this, but they just, in their minds, they don't want 2 accounts. I feel the same way. I would want to just get rid of one account, get rid of, all the administration involved with it. I don't want to see it. There's just one, it's streamlined. So if I can get rid of account A, I will. It's a mistake. If you make that mistake over decades and decades in your life, you can imagine, and for larger or smaller amounts, but over time, that can amount to a lot. This is called debt account aversion. It's one of many, many examples in this field of small mistakes we might think that whether or not we know it's right, we do over and over. Another is in ultimatum games. This has been done around the country, around the world, with different amounts and different scenarios. So let's say you're given $10, the following conditions. Of that $10, you have to offer a portion of the 10 to a second person who also knows what's going on. If the offer that you give them is accepted, then you both get to keep those amounts. If the offer is rejected, you both get nothing. So when I studied economics in college, that was my undergrad major, we were taught about the concept of wealth maximizers, rational financial decision makers, which is generally when you're faced with a financial decision, a rational person will always attempt to maximize their wealth. And this was an example in literature that basically showed that this is not true, and also was part of what went into the prospect theory and predictably irrational financial decision making. And here's how it plays out. If I offer you $5 of my 10, you'll say, okay, that's perfectly fair. Thank you. We both get 5. I accept. The other person accepted the offer. We both go home with $5. If I offer you $6 and you get 4, you're just going to say, okay, I'll take that. You were the one who was offered the $10 in the first place. When I offer you $3, some people are starting to say, I'm not so sure anymore. When it gets to $2, I offer you $2. Most people at this point are going to say, you know what? Forget it. You know what? I'm rejecting it. We both get nothing. That is not a wealth maximizing position. If this is free money, $2, $1, my best financial decision is to accept the deal. but I don't. And why don't I? Because financial decisions aren't about just the money itself, right? Why? I'm angry at you for having the gall to offer me $1 or $2. So I'm angry and I'm spiteful. And I think this is unfair. And I think you've shown me a lack of respect. So you know what? I'd rather bring us both down. Well, that's not rational, but that's how we make decisions sometimes. So this has to be factored into economic theory, and now it is. So the best financial choice for the recipient of the offer, yes, take anything, but that's not what people do. Another example is brain damage good for investing. Now, who would think to actually look into this? Well, our incredible colleagues over at Stanford did a study on brain damage in emotional areas versus normal controls. And those emotional areas were the amygdala and the anterior insula, where people had damage, and they involved in controlling how we perceive risk. So here, participants were given $20 for every 20-round gambling session. And how it works is like this. Every round consists of a coin flip. You can either play each round at a cost of $1 per round, or not play, right? And so now if you play heads, if it comes up heads, you get $2.50, $2.50 back. If it's tails, you lose $1. So what's the best play here? The best play, best plan is to play every round, right? And so because you look at your odds and $2.50 for getting the heads and an equal coin and $1 you lose, obviously you should be playing every round. But what do people do? Well, what people do is what people do for other reasons, which is you get 3 tails in a row and you realize I'm gonna cold streak. I better sit a couple rounds out before that cold streak goes away, right? And so people in general, and despite regardless of knowledge overall, will not play every round. They'll sometimes, they'll ride a hot hand, but they'll sit out when there's a cold spell. And so when you compared the people who had brain damage to emotional areas, they outperformed the control groups. So that led in famous, right? The papers were written up, but they also had some articles from the authors. And one of the authors of the papers at Stanford was quoted as saying that, so the best investors are functional psychopaths. Maybe not the best wording that they could have used on that, but garnered plenty of attention and some humor on that. So financial security education, what is missing? We're starting to see it. Behavioral economics, behavioral psychology, neuroscience and neuroeconomics, age-appropriate methods, and we need to measure and validate the program that we're doing. When we've looked into a lot of the programming around the state and country, there's a lot that's going on out there that's not actually, they're not measuring what they're doing. You'll do some kind of surveys after, did you enjoy the course that you just took? And people say, yeah, and potentially even pass a test right after you took that course. Okay, great. And then you can write that up and you can put that in your literature, but not actually measuring the impact of what you're doing and if it's having any real effect. So the second solution, near and dear to my heart, is screening and prevention. This is not a consensus solution. So let's look at a couple just kind of bread and butter cases. And my training is in internal medicine. I was a hospitalist after medical school and then outpatient primary care internist for a bunch of years after that. And as you all know in geriatrics, unfortunately, a lot of our older adults are not being seen by people who are trained to see older adults, but they're seen by family medicine docs and internal medicine docs like myself. And so a huge amount of our panel sometimes are older adults. And so we need the training. Everyone needs the training who's going to be seeing people who are older adults. And so real easy bread and butter. 68-year-old man, history of diet-controlled, high cholesterol, presents just for an annual visit, a well visit. He's got a family history of coronary artery disease, does some regular exercise with walking. He admits that his diet could be better, and says his wife tries to help him with his diet. Otherwise, he's happy. He feels well. He has no complaints. Review system exam is within normal. He's got a mildly elevated BMI. Okay. So what does an IM-FM doc do with this case? Well, we're going to go through a lot of screening, right? Colorectal screening, as you had a colonoscopy. We'll have a prostate screening discussion potentially. We'll look into the blood work and obviously get into the cholesterol, vaccinations, immunizations. We'll give him his flu shot. When the COVID vaccine comes out, we'll sure to hopefully give him that if it's safe and well vetted and done the right way. We'll discuss vision, hearing, address mental health, address advanced directives, hopefully. But generally for the FM, IM docs, probably a lot of your visit is going to be spent digging into the heart issue, the cholesterol issue, and the weight issue, and really discussing, well, what are you doing for diet and what are you doing for exercise and how can we do better, and let's get the results of the cholesterol back and see if there's statin therapy is indicated based on the results and things like that. And that's our visit and our follow-up, and generally a lot of people are going to feel very good about that. So before discussing further, let's move to a second similar case. 65-year-old healthy female presents also for an annual visit. Her big thing telling you is that she quit her job last year to take care of her mother, who's had Alzheimer's disease for many, many years. And she reports that she's lonely now and has higher stress because of this caregiver role. And incidentally, because her sister's upset with her for missing a bill payment for their mother. And this is what she's talking about with you in that day, but otherwise no complaints. And again, exams normal, review system's normal, and seems to overall be doing fine. So we might have a similar, what will the docs do in this situation? Similar screening discussion will obviously include breast cancer screening, cervical cancer screening, get into the stress and anxiety, hopefully testing on that, potential look into depression. But are we diving into the social isolation aspect here? Are we diving into the family history of Alzheimer's disease? And are we having a discussion about healthy brain behaviors like we do so often with our heart patients or our diabetic patients? And what about, are we asking about that missed bill payment? Is that a habit? So Dr. Lauren Hirsch from Johns Hopkins actually came to CU School of Public Health earlier in the year, did a fantastic talk, and some of the research that she's looking at in her group is Medicare claims of tons of people, and finding that financial symptoms such as payment delinquency can present years and years prior to any clinical diagnosis of Alzheimer's, and that there was that correlation there. So my questions are we missing some opportunities for optimal patient care here? Would a standard screening test be useful? And should we be asking different questions? So with screening and prevention, heart disease, we're getting at this decades before, right? We check cholesterol in kids. Diabetes, same thing. Blood sugar early on in kids. Cancer screening with colonoscopy, mammogram, other screening. Excuse me, not only are we testing, but we're having extensive discussions on these things regarding what you can do as preventative in terms of your lifestyle. Sometimes there's support groups, there are all sorts of lifestyle interventions. What about for dementia? And going back to those initial slides of how significant and important this is from an individual standpoint, but for families and for caregivers and the cost itself. Are we having those same types of conversations? And if not, why not? And shouldn't we be? One of the issues is dementia. It's not a binary determination now, is it? It's a process that takes years and perhaps decades to happen over time. But yet we're potentially going to make that diagnosis in a day, or sometimes when people are unaware of what's going on with a patient who comes in and they're told by the spouse that they can't remember, they want to take the driver's license away because having all these issues the first time that the provider is having any awareness of this, and before you know it, they leave with a diagnosis of dementia in a process that's probably taken more than 10 years to happen. So there are challenges in determining consent, capacity, and competency. And these are not just challenges in our area in internal medicine. I give some talks for continuing legal education as well. And the American Bar Association and the American Psychological Association have, in collaboration, come up with a fantastic document, book, the Assessment of Older Adults with Diminished Capacity. And that's a handbook for lawyers, but it's actually a fantastic document for anyone who's not a clinician in our field or health professional, but wants to get at, well, how can I help with this situation? Because the truth is that the front lines of dementia are often not the healthcare team, but it can be lawyers, it can be financial professionals, it can be at your bank, it can be almost anywhere. So the more we can get information out, the better we are. So this capacity for worksheet for lawyers looks at observational signs of diminished capacity, mitigating factors, transaction-specific elements of legal capacity, task-specific factors and evaluating capacity, preliminary conclusions about client capacity. And when they look at possible signs of incapacity, there are cognitive signs, behavioral signs, mitigating factors. And if you look through this list, this is a fantastic list, well, I think for everyone to look through. And obviously, people who are trained don't need this document from the American Psychological Association along with the American Bar Association, but it is a great way to get information out about some of the things that we might be looking for in terms of signs and mitigating factors also, because sometimes people will jump to the conclusion wrongfully that there might be some kind of cognitive problem when actually it's a response to grief or depression or hearing or vision loss, some of the other things that obviously can confound what looks like cognitive impairment. So we want to protect our financial health and enhance our cognitive health, right? Simultaneously, we'd be a lot better off if we did both of these things. So what can we do? This brings me to the concept of cognitive reserve, which is, the scientific concept that there's a lifetime of buildup of alternative cognitive processing pathways that are neuroprotective and that lower our risk of disease and lessen symptoms of any disease should it occur. One of the examples we do a lot is in the compensatory heart example, where someone will tell you the story, and everyone's heard it or seen it, or from a clinician standpoint, of the person who had a massive heart attack, and by all accounts, the doc said that they should have died, but somehow they didn't. And how was that possible with a 99% blockage in multiple vessels? And how was it? Well, the cardiologist will explain, well, actually, over time, you've done some nice things. And maybe with good exercise and diet, you've developed collateral arteries that are delivering oxygen to parts of the heart. So even when you had a complete blockage, you were able to still supply the oxygen and keep everything going. And so it wasn't a fatal event. Well, thought to be similar in the brain, where there are alternative pathways depending on how we act in our lives. And so, another example of this is there's a famous study many years ago, the nun study, where they looked at cognitive function of around 700 nuns and yearly cognitive function tests, and then did autopsy on those who were willing after death. And lots of amazing research came out of that. But one of the interesting anecdotes that led in large part to a lot of the research in cognitive reserve was this case of Sister Mary, who died when she was 102 and was remarkable in that sense. But she was also remarkable because her cognitive testing was fantastic throughout almost her entire life until the last few years. But on autopsy, they found significant Alzheimer's disease in multiple areas throughout her brain. So how is it possible that she had bad Alzheimer's disease and yet was functioning perfectly well? And this is, it started to look, why did they use nuns in the first place? Because these are people who don't drink and treat their bodies well. They're also, generally speaking, when they're looking through, people who practice gratitude, who are nice to each other, who are socially active people. Sister Mary herself was someone who was engaged in active learning and teaching through her 80s. Well, it sparked a lot of the interest in research in cognitive reserve field, and how can we do better with lifestyle initiatives. And so protecting and enhancing cognitive health is about, replacing the old myth that we're born with a certain number of brain cells and that over time we just kind of slowly kill them off or with age they go away. And we know that that's largely untrue, that of course we can make new brain cells. And so while there might be some decline, and the decline gets a little bit greater over time, we can make new ones. And not only can we make new ones, we can strengthen the ones that we make and the ones that currently exist, neuroplasticity. So, I sometimes will, in some of these talks, say, well, what if I had a treatment for you? And this treatment can measurably improve your memory. It can improve overall cognitive function. It can improve your ability to learn new information. It can improve your mood, your ability to handle problems. It can enhance your metabolism, lower your risk for heart disease, and perhaps increase your immune system's response. The treatment once a day, and it's free. Would you be on board with that? What is that? The sleep. Sleep. We do a terrible job in this country and around the world with paying enough attention to healthy sleep behaviors and sleep hygiene. And I'm not talking about the doctors who are throwing unnecessary medicines at sleep, but I'm talking about, well, how can we get at this the best way possible? First, by identifying what a significant issue it is, and then get going after every possible healthy way with regards to sleep hygiene aspects of, well, how can we do better, because how important it is, and the number of studies on this. Well, what else? So there's clearly many studies on that. There's also learning. More and more studies on learning, and this is also spurred on the brain game billion-dollar initiative. Plenty of people just trying to make money because learning is supposedly good for you. And largely, a lot of these brain games, they show that you end up being much better playing that game, but not much else. And so what's starting to come through with that is we know that education is very important. It does seem like the common denominator is that challenging your brain, continuing to challenge your brain, is probably at the heart of why learning is very important. So it's not necessarily getting comfortable doing one thing and doing that over and over and patting yourself on the back because you're a Sudoku champion, but try to learn a new language, try to learn an instrument, engage with people in terms of conversation. And so active mind in that way it seems to be more where we're going. We're going to have to follow that. Exercise and activity. Now, clearly, something we all know, but we probably don't pay enough attention to. As good as it is for the heart, it's also amazing for the brain as well, and not necessarily in the same way. So there are some studies that pointed out that high intensity interval workouts are probably a little bit better for the heart than they are for the brain, although good for both. But low intensity efforts in exercise might actually swing a little bit more towards cognitive power and enhancement than the high intensity. Now, I think what if you look at all the studies in entirety, it does seem like, look, it's all good as long as you can do it. And then if you can start to potentially go towards one direction because you know that that's good for one thing that you want to do, that's great. So the lower intensity, like walking. So plenty of the studies on walking are shown to be really good for the brain. And brain changes, I mean, we're seeing increased brain volume, decrease in age-related holes, in white matter, gray matter, the brain cells themselves, great studies on this, increase not only in quantity of neurogenesis happening, but quality and functionality of these cells. So, longer dendrites, when the snaky tendrils that help cells form into neural connection networks. So really fantastic studies on that. What else? Social interaction, an exploding field that becoming more important, especially in this pandemic, but obviously been known to plenty of all of us for some time now. It's a growing field of research confirming essentially the components of social interaction in cognitive health, as well as overall health, attention, memory, bolstering cognition, decreases stress, decreases depression. In fact, there's evidence that overall the social interaction may be as important as the exercise component for our brains. Mindfulness practices, studies continually, studies. So whether it's on what types of mindfulness practice, that can be meditation, yoga, Tai Chi, Qigong, plenty of different modalities of how this has been studied, but also confirming and with, again, brain changes, and also the strong correlational data on processing speed and attention, creativity, mindfulness practice. Let's see, nutrition, obviously very important. So we talk plenty to our heart patients about what's good for the heart. And a lot of times there's plenty of overlap, but it's not exactly all the same. And so the Mediterranean diet is fantastic and has been looked at, but then that got transformed a little bit into trying to get a little bit more targeted towards the brain and the mind diet. And so studies on that, and looking at omega-3s and resveratrol and flavonoids and curcumin, things like that. And so there are plenty of good studies on this as well. And then music, decades of studies on music that seems to be overall protective and helpful, that maybe playing is better than listening, but they're both fantastic, stimulating the brain in different ways. Musical training enhances verbal memory, spatial reasoning, literacy skills. There are long-term benefits to children who play an instrument, long-term benefits of that. And then finally, nature is also a field that's gotten more and more attention over time, that basically, people, you walk in a nice setting outside versus in your gym, you're getting a benefit from the nature itself. And so this is a really interesting field that I've been following. And so we need to find more information on this, but it does seem like there are plenty of studies on improving with depression, improving with anxiety, concentration, memory. And in terms of these mental health aspects, we also know how much all of this is tied together. So part of the reason potentially that if one of these practices increases your mental health, that it's going to have that increased cognition and overall health as well. So all of these things that we can do, we know plenty of studies about them. How much are we talking about this in terms of protecting and enhancing our cognitive health, neurogenesis, neuroplasticity? Are we having these conversations? So to sum up, there's a lot here. The consequences of poor financial decision-making and declining cognitive health that's not being addressed or treated, well, there's staggering amounts lost to financial fraud and exploitation for sure. Even much, much more lost to poor planning, poor financial decision-making, or suboptimal decision-making for all these other reasons. And financial well-being has a significant connection to cognitive health, to emotional health, and to overall health then. And all this has a profound effect on individuals, on caregivers, on families, also on stress, social services, and healthcare spending, and I would make the argument on economies as well. So we are now again called the Paul Freeman Financial Security Program, formerly the Financial Security and Cognitive Health Initiative. But what we're up to is diving into all these areas. One of the things that's been actually the most fun for me is that with my training, no one can really own this field because there's so much to it. It is naturally a multidisciplinary field. And so when I got to DU to set this up, and to start off this initiative, the first thing I did was to meet everyone, different academic disciplines. And so on our team right now, we have people from the business school and the law school in psychology, social work professors, neuroscience, engineering, because there's we're forward looking to technological solutions to a lot of this as we go. And statistics, because the measurement aspect also is critical to all of this. So it's fun sitting around a table with people who know so much more than you about so many different areas, but then we bring it all together and come up with what I think are the only ways to address these issues of that intersection between financial decision-making, financial security, and health, cognitive health, emotional health. So what we're up to is we're developing. We have already developed one practical and accessible test for early indicators of impaired financial decision making that perhaps would be that indicator of future cognitive decline. And what we're trying to do with that is that you'd pass a mini mental, you'd pass a MOCA, flying colors like our president. You'd get, but yet there might be these indicators buried there in this information that actually impaired financial decision-making might be that first sign. Well, we would like that to, instead of being buried in this beautiful literature over the last 20 years, but to be distilled down into a practical and accessible test that can be taken, whether it's in a healthcare facility, or in a bank, in a financial institution, in a law firm, anywhere. And potentially that's even on your phone, not an app. And so that would be the way to spread this out there. And people could have a telltale sign. Looks like there might be something here. I better get this checked out. Go to you guys and get it checked out, or to us or our family medicine colleagues. This is one of the things we're up to. The other big initiative is the education aspect. We have been working with the Colorado state government on this, and the Kansas state government as well, but also all the community centers and the initiatives around who do financial education. And I'm part of a lot of these groups. And really the desire there's a lot of good people who want to do the right thing, but there's a lot of wheels spinning. And so how can we do better? And so we've already created one targeted financial education program targeted for older adults that gets into all of these aspects that we're talking about that are missing in other financial education programs. We're also measuring it and following people over time and seeing what comes of that. We want to get into the space and have developed several different opportunities and frameworks for the K through 12 adults, as well as the older adults. And we're getting into initiatives and education for financial industry frontline professionals, who are often the first people who see this. A class that I taught on this out of the law school at DU we brought in financial planners and registered investment advisors, and they'll tell you the exact same thing. They see this, they're talking to their clients about these issues, they can see that something's going on, but they don't know what to do with it. And otherwise, these people are at the top of their game. We want to create some education and training for those financial professionals, as well as the other thing I'd love to do is get into potentially discharge planning at hospitals and clinics on specifically what can we be looking for, what can we do, and how can we help people with preventative measures and lifestyle measures, and what things to look out for individuals and for family members. The other is the collaboration on policy and practical solutions guidelines with the financial industry, with government, with nonprofit, for-profits, and the community at large. And so that's generally what the program's up to. And I'm happy to talk further about this, but I really appreciate the opportunity to be with you today. And that's it for me. Thank you so much.
Thank you so much. That was a wonderful presentation. We have a couple of questions that have come in. So the first one is in regards to the financial security program. Are you taking referrals for financial decision-making assessments, or is the initiative more about developing tools only?
We are not yet taking referrals for, and I would imagine for individuals who are looking to assess themselves. We're doing this more through the research aspect yet, or so far. So we've gotten this question, and we would love to in the future actually expand to be able to have that platform. We're just not quite there yet.
Thank you. Another question is whether you're developing your screening for diverse populations, including marginalized older adults.
Yeah, and this is I'm so glad you asked this question. Largely in our meetings, this is the focus, because the people in this group, like I mentioned, these are social workers and psychologists, and even the people from the business school and statistics. Our major goal is not to help people who already don't, need the help, and not to exclude anyone, but really our focus here is, and on one of those slides, and we have a lot more information on this, but the marginalized communities are hit the hardest by this issue, like so many other issues. And so the goal here is really to get as much diversity in the research and information that we can, so that we can also provide the targeted solutions to specific groups, because this kind of one size fits all type of solution is not what we think is going to be the answer. And we need to get to know, well, what's affecting people, how, and also about how they're making decisions. So this is a core key component for all of us, at the heart of what we want to achieve is the diversity in our population, in our group as well, and achieving those solutions to help marginalized communities. Absolutely.
Thank you. And then a question is whether you're partnering with any elder law attorney groups.
Yeah, that's a good question. So I've given a number of talks. Largely in the beginning, we stayed away from partnerships with for-profits, in part because we did not want to have any appearance of any impropriety or that we're having any business go towards certain direction. We've had a lot of different interests that if we could put our stamp of approval on something, that would be helpful. But we felt initially that was going to get in the way of the quality of the research and how it was perceived. Now, I will say this: we're starting to branch off from that a little bit. And for instance, there was a company, after an op-ed that I wrote, there's a company in New York that had reached out and really just they thought they were doing some good work, and of elder law attorneys who are doing work in financial security, and wanted program evaluation work and how can potential collaboration happen. And this kind of got through to us also because AARP was behind this company and the work that they were doing. And so we are starting to build potentially more of those, but as of yet, it's been pretty much in-house academic research and involved with the community. We do a lot of outreach, but we wanted the research to be as pure as possible at the outset.
Thank you. And just a couple minutes left. So one final question that's come in is whether you could talk more about the testing you're developing as an early indicator and what stage that's at right now.
Yeah, no, I'd be happy to. Well, so the initial idea is when when you pour through the literature on this, is, well, how was all this being come up with that some of the financial impaired decisions were happening as a early indicator, and what were they looking at? And so sometimes it was impersonal and looking at large sets of data and finding out that, like in Dr. Hirsch's talk, that just largely forgetting to pay bills might be an indicator. But then on all the other issues of, well, what about making tips or spending decisions or selling your house to your son-in-law? Or now some of the research done by, there's a limited number of people who have done this research over the last 20 years. And so there's some godfathers in the field, and that's probably the wrong term. But Dr. Peter Lichtenberg is one of them. We've been in good contact with him, and what he does is these very in-depth analysis that require basically PhD candidate or higher to go through hours-long testing of people of personal situations on decision making. And so obviously that's, for us, that's why I say practical and accessible a lot. Is that's fantastic and it's led to this field. But what if we could distill that down? So we're trying to from the testing that he's done, along with the testing that's been done, just straight up neuropsych testing. So what are the key elements, let's say, from the MOCA that we would want to include? So we basically took some financial decision-making, some fraud risk questions, and some standard neuropsych questions, and distilled them down into a 10-question test that we are currently doing research on to see what we have there. We're pretty confident that this is not going to be the answer yet, but that we're making a stride, and so that our first shot at it will not be our last shot. And so where we are on it is that, yes, we have developed a test. We have a bunch of data back on that test. We see the possibility for a lot of improvement with that test, and potentially a slightly larger test. This one was just a real quick 10-question. We might expand that a little bit, and we might get into some other slightly different nuanced realms of decision making. So we're in basically a phase 2 on that, I would say.
Thank you. Well, we are at 8:30, so we're going to go ahead and end the session. Again, Dr. Chess, thank you so much for a really wonderful presentation. And thanks to everyone for participating. And please check your email for the evaluation and the links to the slides in the presentation. So Thanks, and see you in 2 weeks.
Thank you.